All right. What's up, guys?
Nothing much, Avi.
How's everyone doing?
Fine.
Fine. Better than fine. You're ready to do some Dermpath, right?
Hell
All right. You're up first then. Let's do it. What does this look like to you?
yeah. Well, it looks it looks like a neoplasm.
Yeah.
There's not any type of like infiltrate. It's well circumscribed,
Mhm.
benign appearing. Um, there's an abundance of, it seems like, uh poroid cells.
Yep.
This looks like a poroma.
Okay. If that looks like a poroma, what does this look like?
Oh. Is this a hydroacanthoma simplex?
This or this? And what's the difference?
Um, I think that the Paroma, honestly, I don't know. I do
Sure,
not
sure.
know.
So, does anyone know?
Like, well, as far as I understand, hydroacanthoma simplex is also known as like a wholly intraepidermal poroma. So it's like a variant of poroma, whereas the entire thing is like inside the
Okay.
uh, epidermis.
What
Whereas
about this one then? How would you classify this one?
this one looks like it's wholly intraepidermal.
Wholly intraepidermal, so you would call this
Hydroacanthoma
a
simplex.
hydroacanthoma simplex. And this, how would you classify this one?
That one looks, I don't know, like it's like a mix.
Is it only in the epi?
It's dermal and intraepidermal.
Okay, yeah, it's epidermal and dermal, right? Otherwise the same. Monotonous cells. Some have described them as polyhedral. If you look hard enough, you'll see the ducts. Fibrovascular stroma. So what is this?
Again, hydroacanthoma simplex.
So hydroacanthoma simplex would be
CEO.
what?
Do you want me to get headphones?
What?
Do you want me to get headphones?
Let me just.
Yes, Lauren.
Yes, that would be a good idea.
I mean, I don't fully understand the classification, but this would be like a poroma.
Yes, it would be a poroma. Yes. So this is a hydroacanthoma simplex. See how it's just epidermal? In fact, you can even see like a lining over it. It almost looks like it's encapsulated in the epidermis. See how there's this lining of like normal epi that almost looks
Seems
like
like a pseudo capsule or something.
It's not a real capsule. Yeah, no, it's not. And you don't always see it like this, but this is just this is wholly epidermal. But this is clearly not, right? This is clearly going into the dermis. So it can't be a hydroacanthoma simplex. We have to call it something else. So what are our options? If it's not just
it's like this poroma dermal duct tumor and then hydroacanthoma. So this is dermal duct tumor.
Our options for, so remember, hydroacanthoma simplex is just in the epidermis.
Mhm.
Isn't
So if
dermal
it's-
duct tumor just in the dermis?
Yeah, so if you just saw this,
This
me
is
what
dermal
this
duct
is.
tumor.
that
This
would-
is all just like
this
in
is
the
dermal
dermis.
duct tumor, right?
Yeah,
But what about, so then this is what?
epidermal and dermal.
Which is it? So that would be a
Poroma.
poroma. All right.
Okay.
It's like,
So-
I don't know, what you call it, Ali Khan has it where it's like poroma, and then under poroma they have three classes, like classic poroma, hydroacanthoma simplex, which they call wholly epiderm, like WHOLLY, intraepidermal poroma, and then there's dermal duct tumor, which is wholly dermal poroma, and then classic poroma, which I
Yeah,
guess.
so he's grouping them under poroma. So there's another word we use to group them. There, it's called the acrospiroma family. And underneath the Acrospiroma family, we have Hydroacanthoma. I mean, it's semantics. It doesn't matter what you do, but for the purposes of the boards, this is the classification you need to know. So there's an Acrospiroma family. Within the Acrospiroma family, there's a Hydroacanthoma simplex. That just means it's an Acrospiroma that is just in the epidermis, just like you see over here. Now, the next step in the Acrospiroma family is the Poroma. It is epidermal and dermal. The next step in the Acrospiroma family is the dermal one, which is dermal duct tumor. And what's the next one in any other Acrospiromas?
Hey, Avi,
Yeah.
Shane here. Yeah, so for everyone, just to simplify, they're all poromas. And then, yeah, like Avi was saying, it's semantics. And so equine acrosporoma is a very dated terminology, but it sounds like certain people writing the boards tend to use that, or it can pop up. But the important thing to realize is that they're all the same cell type, and just depending on where they are, they use a different name. And then, yeah, poroid hydradenoма is another one to kind of confuse everyone.
Exactly. So if you see this, yeah, so this would be dermal duct tumor. See how that's just in the dermis? What about this one?
This looks not good. This looks like a porocarcinoma.
Well, okay, porocarcinoma is on the differential. We're gonna obviously not jump the gun. We're gonna look at the cytology. We're gonna make some evaluations on low power before we call that.
It looks more nodular
It is nodular.
than the other one.
So it has a nodular component.
It appears to be like a hydradenoma that has like multiple components, like a cystic versus.
Yeah, it has a cystic component and it also has a nodular component. And you said hydradenoma. So what tips you off to hydradenoma?
So there's like I remember there are 3 different cell lineage, like a poroid, squamoid versus clear cells. I think there are definitely some epithelial, like squamous type. I'm not sure if I can see some clear cell.
Okay, so yeah, so there is some biphasic, so it has a biphasic, the nodular component does have a biphasic pattern in the sense that there are clear cells with an eccentric nucleus full of glycogen, and it also has the classical polyhedroid cells that are not clear cells. What about the stroma?
Sclerotic.
Yeah, it's fibrotic. It has that. Burn this look. See how this look is? It's like a very fibrotic, almost like it has like pinkish red. It almost is reminiscent of like the keloidal collagen, but not quite like that. Some people call that poroma stroma. I kind of like to call that hydradenoma stroma because I kind of see it more often in hydradenomas than poromas. But this stroma is really good for hydradenoma. And like you said, it's nodular and there's cystic components as well. You mentioned there's a lining. There's some areas. Yeah, like this stroma here too. Now, someone mentioned hydradenocarcinoma. I'm glad you mentioned that. Let's work through this one. So similar low power architecture, right? This also has a nodular component and a cystic component, just like this one did. We're noticing some differences though. What's different about this?
It looked like there were areas of hemorrhage at high power.
Yeah, so let's see. Is it hemorrhage?
Not in this one and the other one, but I could still be wrong. It could have all been just like hyalinization or like necrosis.
Necrosis.
rather.
Okay, now you can get necrosis in benign things. So nodular hydradenomas, you can get necrosis on moss. So it doesn't necessarily mean. Oh, Shane's pointing out it's hyalinized stroma for the hydradenoma instead of, I was saying fibrotic stroma. Yeah, that hyalinized stroma over there. This stroma is really good for hydradenoma. But notice this. So what do we call this?
Necrosis?
Yeah, there's a lot of necrosis on moss area. You can see that sometimes in benign entities. What else is there?
Atypia?
Atypia. There's a lot of atypia, and there's also something else.
Are there mitotic figures?
There are
Or am I
mitotic figures.
imagining that? Yeah, okay.
There are actually quite a few mitotic figures. In fact, this is very mitotically active. There's one here, there's one here, there's one here. So with that, with the necrotic moss, architectural complexity, mitosis all over the place. This is good for what?
Hydradenocarcinoma.
Hydradenocarcinoma, as opposed to this it's more benign variant, hydradenoma. One other thing. This one. What do you guys think about this one?
It looks more infiltrative.
Yeah. In fact, see that?
Yes, down to the fat.
Down to the fat. Okay. So you mentioned the circumscription. It does not look circumscribed. I agree. What else are we looking for?
Size.
Size. Is it big?
And then symmetry.
Yeah. Is it symmetrical?
I mean, we won't see the whole thing, but from top to bottom, it doesn't.
Yeah. In fact, you notice something different?
There seems to be a clear-cut border between something that looks okay, like Paloma maybe like, and then something that looks a little bit more nasty.
Good. Exactly. So let's look at the okay part. And you're right, it looks okay. In fact, if I were to just see this, you would call this a poroma or a dermal duct tumor. But then we get something happens, right? So even from low power, we're seeing that this is a different color. Why is it a different color?
Probably more like hyperchromatic nuclei.
Yeah, the
or just
nuclear to cytoplasm
active.
ratio is higher in the bottom part than the top part. And what else are we noticing about the nuclei? So now you already mentioned it, actually.
Hyperchromatic.
Yeah, the nuclei are hyperchromatic, a bit larger. Let's see. There's another thing that, and in some areas you may find mitotic figures as well. Some other things that you can find on this, well, you also see this, which is, what's our good friend again over here?
Necrosis.
Yeah, necrosis on moss. There are various areas where this is necrosing on moss. And then there's something else you can see in porocarcinomas. I don't always find them, but tell me about how many ducts do you see between the poroma area and the porocarcinoma area?
You seem to be more.
It's very flagrant in its ductal differentiation. Yeah, so sometimes in these transformative entities where you have poromas into porocarcinomas, in some cases you can see it just starts making a crazy amount of ducts. Usually in poromas, it's hard to find them. Don't judge it based on that. If it's like, don't go like, oh, it doesn't have like easy to find ducts, so it's benign. Obviously, the other features that we talked about are going to trump that, but that's just one little potentially helpful thing that can clue you in. Sometimes when porocarcinomas happen, they can have these really flagrant ductal differentiations. Like it's like all of a sudden the ducts are easy to find. But yeah, the other features are really what should clue you into porocarcinoma. Okay, so that was our outdated term acrospiroma family. What's this?
It's a paisley tie.
It's actually me, but I am wearing a paisley tie. You're right. Yes, it's a paisley tie. What's
Sorry
a
for
paisley tie?
objectifying you.
What's our Paisley tie differential?
You want me to name all of them?
Yes, I want you to name them.
Morpheoform BCC,
Okay.
microcystic adenocarcinoma,
Very persistent
syringoma,
adnexal
adnexal yeah, syringoma, and help me on the other one, guys.
Desmoplastic
That's it.
trichoelioma, I think.
Okay. So what do we think about this one?
Appears to be like kind of eosinophilic, like red dermal nodule with from the low power.
Mhm.
And then I have to really take a closer look. There may be some Paisley structures.
Yeah. What else? Anything else you're noticing from low power?
Also there may be I don't know, this like inflammatory cells
Yeah.
with a deeper.
Yeah, all these inflammatory cells. See all this? These conspicuous aggregates of what? What kind of inflammatory cell do you think they are?
Lymphocytes, probably.
Lymphocytes.
Yeah. And why are you saying lymphocytes as opposed to like histiocytes or something from this power?
Looks more black.
Yeah, jet black. Jet black on low power, probably lymphocytes. So you have these aggregates of these conspicuous aggregates of lymphocytes. You have what about the size of this tumor?
Large.
Yeah. It's pretty large. And you mentioned there's Paisley tie. Okay, do you see the Paisley ties now?
Yeah, closer.
Okay, so what are these structures?
Look almost like keratin.
Yeah. So it's making
Horn
Like
cyst?
keratin. Yeah, horn cyst.
making cysts. Yeah. It's also making something else. So this tumor, see if I could find some good examples. So up top, they make cysts. These cysts are usually larger than the ducts, but this tumor makes cysts and ducts. Maybe starting to get one over here, but I don't want you to recognize it by going duct hunting. Like this might be here. That might be a duct. See that? Okay. Yeah. Okay, so cysts and ducts, and it's like, tell me about the depth of invasion here.
Deeply invasive.
Deeply invasive. All right.
No essential dell.
Sorry, what was that?
Oh, I'm just kind of like going by the Paisley tie difference. There's no essential dell like in
Desmoplastic.
I mean, we already have the diagnosis here, but
Well, if you have the diagnosis, tell me the diagnosis.
Mac.
Yeah, Mac. Okay. So, yeah, it has the piece. So it's making both cysts and ducts. It's really large. It has those, like a low power, you guys noticed, it has those conspicuous aggregates of lymphocytes. One thing I tried to find when I was previewing this, but I can't really get a clear good case is perineural invasion. Like this might be perineural invasion. It's hard to really say. You want to step into that. There's some other nerves I found that were lower caliber, but again, really hard to call anything.
Sorry, Avi, what's the diagnosis?
This is a MAC, a microcystic microcystic adnexal carcinoma. So here's another nerve, like maybe this cell and this cell line. I really can't call any perineural invasion here, but I want you to have your antenna up for that because this tumor is particularly notorious. This cancer is particularly notorious for perineural invasion. So good.
Avi, one thing I'd say about this one, if people haven't seen very many Macs, this is like comically large for a Mac. So most of them are not this huge. So most of them are fairly small.
Yeah, this is a massive one. We're starting on the the most pronounced examples. And then as we progress, we can get to the less obvious ones.
It's more benign. You see the Paisley tie differential, even just from like low power view. It's a bunch of ducks.
Yeah. Okay, so we see Paisley, you see Paisley tie, and you see the ducts.
Looks like it, now it's seeing a hair, could be like an eyelid or something.
I can't really hear you, got to speak up.
Oh, I was thinking, I mean, it looks like it could be from like an eyelid.
Okay, it could be, well, it's a little around that, close to that area. What do you see in terms of the tumor? So we mentioned this Paisley tie, we mentioned ducts. Any cysts or no?
None.
No cysts. And what about its size, its symmetry, its circumscription?
It's well circumscribed. It's relatively small.
Yeah. So what do you guys think it is?
Looks more like syringoma.
Yeah, exactly.
No central dell as well, like Nick was mentioning on the last one.
Yeah, it's a syringoma. Central dell is kind of, I don't know if you can really see that here. You mean the last one? I think that's more of a
No. It's just like
Clinically?
the workup criteria for our Paisley tie pattern, like you would see more so a central dell on desmoplastic trichoepithelioma, but we didn't see these on the last two.
Oh, I see. You may not see central dell on path. I mean, I know you can see the clinically. Like, for example, do you see a central dell over here? May have to step into this to do it.
No.
But I don't want you to rely on that. But like, oh, I don't see a central dell, so it can't be a DTE, right? So we'll go by the histologic features. So yes, you're right. Syringoma, exactly. Where do we see syringomas? Which demographic?
Asians.
Yeah. Typically the prototypical example being young Asian females. Although it can happen in other demographics too.
Like
What about this one?
This one has a lot more going on. This one has some pearls in it. You can see maybe, I guess, like this like palisading of the basal cells to the right of the specimen. I don't know if that's necessarily all palisading.
We're not
Yeah,
really
right.
seeing, you mean, are you talking about this area?
No, a little bit to up, like 10 o'clock of where you just circled. Like where there's like the red center there.
Oh, you mean this structure?
Yeah, like is that
Yeah, so that's a
palisading?
hair, yeah, this is a hair follicle. Look, you could see, you see how this little area, and this is almost like reminiscent of that see how you have this guy over here?
Uh-huh.
Then you have this other structure here. This is a little that's just a little hair. So is this, and so is this. That's not the tumor, but see how that's different from the rest of the tumor?
Mm-hmm.
So like all of this. See all that? All that's tumor.
I feel like this is not malignant tumor.
I feel like that too.
Um,
Tell us
I-
why you feel like that.
I feel like there are some clear cells.
Okay.
Are they clear cells? Because I feel like they're looking pale from the low power.
Yeah, they are clear cells.
So, and then I think there's some type of syringoma called clear cell syringoma. I don't know
There
if
is a
that's-
type of syringoma called the clear cell syringoma.
I think you see that more in like diabetes or
Dude, there
yeah.
is an association between clear cell syringomas and diabetes. So let's describe it. Like, what do we see? We see, you mentioned the clear cells. What structures are they making?
So I think I think they are Paisley structure. Or
Yeah.
they're like, you know,
It is like this is a little Paisley tie. It's just cleared out because they're clear cells.
and those like maybe sweats in the center of the
Exactly. This is a little inspissated sweat over here. And this
How come we didn't
see
really
this?
see that incipate what you just said, Avi, like in the prior specimen? Like, is it just the actual I
Oh,
guess
we do see it. Look.
oh yeah,
here.
just a little bit. Okay. All right, yeah,
Look
you're
at
right.
this. See?
Yeah. I didn't really see it on this on the lower power, but yeah.
All right. And then you see how there's these beautiful cuticles over here. So these are ducts with inspissated sweat. Paisley's high. It's just clear cell. So what's your diagnosis?
Clear cell serongoma.
Clear cell serongoma. Good. All right. Does anyone see a central dell?
Good. No.
I don't see a central dell. So so DTE is out, right?
No.
Allegedly not.
Nope. All right. So what do we see?
That looks like a horn cyst, not like insipid sweat.
Okay. Horn cysts. I agree. What's this little thing here?
Calcification?
Calcification.
Is that calcification within a duct?
So
Or what is it
it's hard to
inside?
say what this was because I don't really see anything. But it sometimes so cysts can calcify, and in this case, cysts typically do calcify in this entity. Tell me about the circumscription here.
Poorly. I mean, it's you can circumscribe it all the way, but it looks like it keeps on going.
Here, I'm drawing it. See that? You see how the tumor, like here's, I can outline the tumor here.
So it's a well circumscribed, kind of like a superficial. It's probably benign neoplasm.
Yeah, the point is that you can make a clear delineation where this tumor is bordering. It's not, it has this kind of like, like it looks like it has this infiltrating pattern because it's in the Paisley tie differential, but it's not like infiltrating like the way our MAC was or the way our other malignant neoplasms were. In fact, you can, from low power, you can kind of delineate where this is. So, I mean, it's fairly large, I'm not going to lie, but it's not, but it is circumscribed. And that, along with the calcification and the pseudohorns and the pseudohorn cyst and we have some some might describe as desmoplasia. What do we think our diagnosis is?
I mean, this would be desmoplastic trichoepithelioma, but what exactly does desmoplasia look like?
Yeah. What's a good way to explain desmoplasia? So the way I like to think of it is I'll start with a ostensive example. You see how this is the normal skin? What does the normal skin look like here? Come on, you know what this is.
Oh, it's also solar elastosis.
It's a bunch of solar elastosis, right? And now look when you get to the stroma of the tumor. All of a sudden, the solar elastosis is gone and it's replaced by all this red stuff. It's like almost starts to look like you have this beautiful new collagen. Here it's somewhat more mixoidy, but it's not. But you can clearly see there's some almost replacement, especially in this area. So it's like these fibrotic areas. It's like a really fibrotic area of stroma. I don't know if Shane has a better way of explaining what desmoplastic.
No, I think that's good. Desmoplasia implies increased collagen, and yeah, fibrosis usually, the way you originally defined it implies that there are increased fibroblasts, and in this instance there are, but sometimes with desmoplasia you don't see so many increased fibroblasts. But you're right, obviously, like increased collagen may or may not have an increased number of fibroblasts.
Yeah.
The only way for me to have known that would have been to have like the comparison of the solar elastosis to like the new increased collagen, right? Like I would have had to know that point of reference.
Well, you'll get a sense of reference as you see a lot of specimens, what looks like, oh, this looks very, like there's an increase in collagen. This looks like an increase in collagen, increase in fibroblasts. When you see specimens over and over, you've seen what normal skin looks like, you'll be able to look at something and be like, oh, wait a minute, this looks like there's some desmoplasia here, or this looks like the stroma is off. It's too fibrotic. So the reason I'm giving you this example is because it makes it very obvious. I'm showing you like, okay, look, clearly there's a difference between here and what's going on here. And that can be a clue to some desmoplastic neoplasms. I have a name for it. I call it the beautiful new collagen sign. So that can be a clue for DTEs. It could also be a clue for desmoplastic melanomas. And some desmoplastic melanomas, you can see something like this, especially useful if it doesn't have an in situ component. So if you don't see the melanocytes in the in situ, but all of a sudden you can see some areas where it's like, wait a minute, like all this solar elastosis is replaced by something that looks like new collagen. This patient get resurfacing or something. That can be a little clue for that some kind of desmoplastic neoplasm is going on.
Got it. Thank you. Yeah, thank you.
All right. I think I put this in for more of the same. Did I put this in? No, this I just put a repeat. Sorry about that. Okay. What about this one?
At low power, this appears to be kind of like a small blue tumor infiltrating into the deep dermal layer.
Okay, so yes, so small round. You're seeing small round blue cells. Okay.
I don't appreciate some like parts like the paisley type structure. Very
Well,
maybe maybe a few. I'm not quite sure.
yeah, this one is sometimes this one it could be even harder to see the paisley ties in a lot of it. I mean, it has some parts that can resemble it, but the reason it's hard to see it in many areas because you don't have the cyst to make up the bulb of the paisley tie or the duct to make up the bulb of the paisley tie.
Also, this tumor is kind of peppered with a lot of inflammatory, lymphocytes. So that's probably not a good.
Not quite. I mean, not a whole lot. I mean, there's a tumor and then there's fibroblasts in the background, and it has what kind of stroma?
Yeah, the stroma looks weird. Is it like
very myxoid? I agree.
Yeah.
So I guess the mucin gives a big clue.
Yeah, there's a myxoid stroma to this. So tumor and myxoid stroma. Is it circumscribed?
Yeah, fairly well. Is this like granuloma? Granuloma?
Oh.
Is it BCC morphiiform?
Yeah, and the point I was trying to make is that it's actually going fairly deep, and it's actually, you see how it is a morphiiform BCC. So you're right. And what are the things that clued you into morphiiform BCC?
Mostly the stroma.
Stroma, yeah, so stroma is helpful. So it has those small round blue cells. It has the in this case, you can see that it has a myxoid stroma, and it has like it would look like it almost looks like an infiltrating basal, like it has an infiltrating pattern, and it does. You can see these little aggregates of basaloid cells.
It doesn't have to have a myxoid stroma though.
No, it doesn't. In
so-
fact, I'll show an example where it doesn't.
Good.
Coming up next.
So they don't rely on that.
Are any other features, Shane, that you rely on for a morphiform BCC?
Well, so they tend to go deeper than they are broad. So it was cool because that a case you showed just before, what did you show another DTE? I just saw a quick snap of it.
This one.
Yeah, and it was nice because you saw that kind of rectangular plaque-like growth pattern that you can see at low power that you showed with the previous DTE. And those contrast nicely with that morphiform basal where it's deeper than it is broad. So that's another thing that can help out a little bit. But yeah, some people wonder there's sometimes the stroma doesn't help, unfortunately, with DTEs and basals and eccrine carcinomas so much. Anyway.
Yeah, and here's an example where there's not a very mucinous stroma. We do have a little something though that might help us.
Yeah, there's some palisading here.
Yeah, and what else?
Clefting.
Palisading and clefting. All right, saved by the palisading and clefting.
Sorry, so that's also morphiform.
Yeah, this was also
BCC.
called a morphiform BCC.
But that one, obviously, so that one we wouldn't. There's morphiform foci to it, but so morphiform we think of as stranding out where the cells are just one or two. The aggregates are one or two cell layers thick, right? So they're kind of radiating out in foci, but most of them are kind of pretty chunky aggregates. So those larger aggregates we wouldn't say is morphiform.
So you say you would classify this as like nodular and morphiform?
Yeah, or micronodular. I think I saw at the edge that there were some, I think, it's probably labeled in path presenters because I think there are some foci where there are thin cords, just looking at the, on my tiny phone.
Oh, over here, probably.
Yeah. It's probably not the best example.
Like the cords over here. Okay.
Yeah.
What about this one, guys?
SPAP.
Good. SPAP from this power. Tell me why you think it's SPAP. And what is SPAP?
Yeah, Syringocystadenoma papilliferum.
Syringocystadenoma papilliferum, okay.
I feel like I don't know if this is like a cut here, but it kind of has like a warty appearance. It has like the what they call it, the fjords and frowns. And then it opens up to the surface as opposed to HPAP.
So it has a papillated structure architecture. It does open up to the surface. And what cells are we going to see in this area?
Plasma cells.
Plasma cells. Did we find them?
Yes.
We did. Yeah, for some reason, you can see plasma cells in hydradenomas and SPAPs, but for some reason, plasma cells really like SPAPs and really prefer to go to SPAPs for whatever reason. I don't really know the answer to why that happens, but it just really happens. As opposed to this, where you can see them, but not necessarily to the same degree. Another low power diagnosis.
HPAP.
Yeah.
So is the main difference between SPAP and HPAP just whether or not it opens to the surface? Like,
So
what
that's
else are
one
we
difference.
looking for?
HPAPs typically don't have a surface connection, and SPAPs do. This other one, you see how it has also like a maze-like architecture?
Yeah.
So the old saying is like SPAPs are the, what is it, the thing you slide in, and HPAPs are like the maze you hide in. I don't know if that's helpful, but
That actually is very helpful.
okay.
As so kind to give us any sort of clinical history, because like I feel like clinically they're very different. Like SPAP is like in children, and like the body, was HPAP is like on the vulva of women.
Yeah, this is typically on the vulva. That's right. But notice how they don't have to give you clinical. It's fair game for them to ask you this, and for them to expect you to just get it without giving you any clinical in the step.
And occasionally you'll see HPEPs connect to the surface. So yeah, you gotta be a little careful with that.
Yeah. And notice how we're not seeing as many plasma cells. In fact, I'm not really seeing a whole lot at all. Whereas in the SPAPs, we see a whole lot. This is a bit larger than we usually see this entity as, but a lot of times it's kind of popped and smushed. So you see a lining with sweat or some sort of secretion, and a really simple lining with some areas of decapitation secretion.
Is it a hydrocystoma?
Yeah, the simplest decapitation secretion, simplest apocrine and next to neoplasm that we typically see. This is just a large example of it. As opposed to this, which is more complex. What are we thinking about this on low power?
There's like this different cell types. I think there's like these areas of like kind of pale, I would say pale blue.
Pale blue, yeah. Almost, is there another word for that?
Like amphiphilic.
What does this look like?
Is this the chondroid?
Chondroid, yes. Chondroid's a great word to
mi-
describe this. I love it.
The mixed tumor, the chondroid syringoma.
Okay, yes, mixed tumor, chondroid syringoma. Okay, so why are we saying this is a mixed tumor? What are the features? What are we noticing?
So you have two
I-
components. One is the myxoid stroma.
Mixoid or chondroid. So some
Chondroid-
areas could be mixoid, some
chondroid,
areas could be chondroid,
stroma,
or
and-
sometimes you can just have one or the other.
And then you have like the epithelial, apocrine or acrine component.
Yeah, there's an epithelial component. In this case, which one do you think it is?
This looks like an acrine component, acrine gland. Not apocrine, correct? I'm not quite sure.
Apocrine, yeah, apocrine. So okay, good. So you point out there's an epithelial component. There's a lining. So biphasic, there's an epithelial component, there's a myoepithelial component, there's a stromal component. Good. And yes, you pointed out and again, do you guys think this is benign or malignant?
Benign.
Benign, yeah. Good. And notice, you pointed out that it's chondroid. What would you describe the stroma like? Let's see. What about in, this area? What's the stroma?
Myxoid.
Myxoid. What about in this area?
By
See these?
cut
What do these remind you of?
bone.
Cells in the lacuna? Well, it doesn't have to be bone. I know it has a little more. Like chondrocytes in their lacuna. So this is more myxoid, that's more chondroid. I know it doesn't have that. So see how there's this has a more mucinous look with fibroblasts, and all of a sudden here you get these cells that look like they're in lacuna. So this has both what? What types of stroma does this have?
Both
Chondroid.
Yeah, myxoid, and it has myxoid areas and chondroid areas. And again, we have the epithelial lining. So the point here is just it doesn't always have to be that chondroid look. You can have myxoid areas as well for a mixed tumor. But yes, the chondroid, the way they like the classic, the easy way they test it, they'll give you something like this. Oh, chondroid syringoma. But if you see a stroma like this, it doesn't mean it's not a chondroid syringoma. You can have mucinous area, myxoid areas. Okay. What do we think about this?
It's large.
Yeah, big blue tumor.
Okay. Large. Circumscription?
Well circumscribed.
Well circumscribed.
Are there areas of necrosis?
There might be. We'll check. Symmetry?
Pretty well symmetrical, asymmetrical.
Fairly symmetrical. All right.
Oh, is this spiradenoma?
Yeah, and why'd you say spiradenoma?
It's sort of like a pepper with the lymphocytes.
Yeah. So lymphocytes, and anything about the stroma you're seeing?
Hyalinized.
Yeah, it also has that hyalinized look to it. And where do we typically see spiradenomas, by the way?
Brooke Spiegler.
Okay. Tell me about Brooke Spiegler.
Brooke Spiegler is one genetic syndrome where you get multiple BCCs, spiradenomas, cylindromas, trichodiscomas, and it's like a CYLD mutation.
CYLD, germline mutation. Okay. And what location does spiradenomas, where do they pop up? You can see them without Brooke Spiegler too, of course. So where do you typically see a spiradenoma?
Like the back, upper back. Face.
Like most common location, if you were to. Yeah, commonly head and neck. The most common areas. Then less commonly on the trunk, arms, or back. And cylindroma, where do we commonly see cylindromas?
Scalp.
Yeah. And these are like on a spectrum with each other. So like, what would you call this one, right?
This looks more like a cylindroma because it has
Like this jigsaw.
in the eosinophilic basement membrane.
Yeah, you see that like hyalinized. It's almost like someone took a pipette and kind of dropped, like pipetted a little bit of basement membrane in the tumor over here. But yes, exactly like you said, it's like some have just described this akin to the pattern of like you see on a giraffe skin. Some have just described this as a jigsaw, whatever's more helpful for you. But these tumors are really on a spectrum to each other.
Also, they were until recently thought to be sweat gland derived, but everyone is now known that they're follicular derived. So that's something you might see in some more recent. There's some confusion if you're using an older text.
Yeah, that's good to know because usually they lump these in with the sweat gland neoplasms in the textbooks.
I'll send you a paper tomorrow.
Yeah.
So, just to clarify, both cylindroma and spiradenoma are follicular derived.
Yeah, they're basically, it's kind of analogous to the Paroma situation where they came up with two different terms for essentially the same neoplasm that just has different patterns. I think also the other thing that was mentioned about Brooke Spiegler, is it trichodiscomas? I think it might be trichoeps. I'm not sure if they get increased
trichoblastoma. I just looked it up, Dr. Meehan. It's trichoblastomas and trichoepitheliomas as well.
All right.
So this one just shows like this is sort of on a spectrum. In some areas, it looks more spiradenoma. In other areas, it looks more cylindral. Okay. Where do we think we are over here?
It almost looks like this like undulating like epidermis. Is this like anogenital?
Well, it's pretty thick. Area where we have thick skin. And we have a lot of deep subcutaneous fat.
The back.
Back is a possibility. Scalp is a possibility. There's something going on in here for sure.
Yeah, it's like deep down to the fat.
All right, but what's going on deep down in the fat?
A lot of eccrine glands.
Okay. What
So
else?
it's
Also
all-
Some
blood
vessels
vessels.
of blood. Yeah.
I'm sorry, multiple people were sitting at the same
Oh,
time.
blood vessels, like Selena was saying.
Okay. Yeah, blood vessels and eccrine glands. A lot of them. See that?
This is an eccrine angiomatous hamartoma.
Yeah, good. Eccrine angiomatous hamartoma. So one of those things you might just like one of those random things they may just throw in there. Yeah, you notice that like, okay, there's none of these are atypical. It's just a hamartoma. They're kind of normal, but there's just a whole bunch of them. And it's the only thing abnormal is how much. And this is just too much of a good thing. And too much of a good thing is a hamartoma. And in this case, the name makes sense. Too many eccrine, too many angio. Eccrine angiomatous hamartoma. Good job. All right. It's another low power one.
Mucinous carcinoma.
Mucinous carcinoma. Good.
You have islands of blue cells surrounded by lakes of mucin or sea of mucin.
Islands of mucin cells surrounded by lakes of mucin. Okay. As opposed to this. Kind of looks like the opposite, right? Now we have little islands of mucin surrounded by lakes of
riverbeds
cells.
of mucin. Yeah.
Right?
Adenoid cystic carcinoma.
No, I don't know. It's not quite. No, what is let's see if I can.
Is this the nipple adenoma?
That's another. Okay, so nipple adenomas can look like this, can have that papillary appearance as well. But this is okay. So location is important. If I told you this was on the eyelid, so this is also from the eyelid, as is this. You notice how some of these areas have these pseudo rosettes? Sometimes you could see a cribriform architecture here. Sometimes you can see pseudo
Not
rosettes.
acrospiroma, right?
I'm sorry?
No, I think I'm very wrong, but I said acrospiroma, but I think I'm very wrong.
No, not an acrospiroma. So this is actually some people think it's on a spectrum of mucinous carcinoma. Some people say this is a precursor to mucinous carcinoma.
It's the EMPSGC.
Yeah, so EMPSGC, which stands for what?
Endocrine mucin producing sweat gland carcinoma.
Yeah, endocrine mucin producing sweat gland carcinoma. A good clue for that is so the first clue is it really is looking like the inverse of a mucinous carcinoma. Like you see these in mucinous carcinoma, you see like this whole pool of mucin. Typically, now you can have areas that are some mucinous carcinomas that are more cellular, but the prototypical look is going to be islands, little islands of cells in pools of mucin. Imagine if that was just completely flipped, inverted. You get this. This is the inverse. You have pools of cells, if anything, and little islands of mucin, just a much less mucin. There's another interesting thing about this. So other features you can see, as we pointed out, the pseudo rosettes. Sometimes you can see a cribriform architecture to this. These stain very interestingly. Well, how do these stain? What kind of markers might EMP-SGC?
Neuroendocrine mark.
Neuroendocrine markers, like what?
ERPR.
So ERP, well, so that's not neuroendocrine marker, but yes, they will stain for do stain for ERP.
Synaptographic.
Synaptophysin, yes.
Synaptophysin, neurofilament,
Chromogranin.
neuron-specific unilase, chromogranin.
Okay, good. Exactly. So EMP-SGCs will stain for these neuroendocrine markers, and some people think they lose their markers when they transform into mucinous carcinomas. Other people think that they're really just mucinous carcinomas that just, interestingly enough, express neuroendocrine markers. You're not responsible to know who's right about that. You are responsible to know this entity, though, and you are responsible to know how it stains. And it can be tricky sometimes. So, like, what would you think if you just see this? What does this look like?
BCC maybe.
Yes, it looks like a BCC. And why does it look like a BCC?
Very basaloid with the clefting.
It is basal. It has a blue cell tumor. Look, in some areas at least, it looks like a blue cell tumor. But there's some areas though that are more pink though. But yes, you mentioned the clefting. And in some areas, it almost looks like it's palisading. But what's off about this for BCC?
It doesn't look like there's a reaction in the stroma, and also you have those little kind of looks like maybe ducts.
So there's some adenoid component to it, and that you can see that in BCCs. So you can see sometimes you can see this cribriform adenoid type of look in basal cells. So that actually also can go for BCC. So it's tricky. This can be a trick. Well, let's take a look at a couple things. So take a look at this area. Does this area look like palisading the way BCC palisades?
Not really.
Yeah, how would you describe the cells? They almost look like cuboidal.
Mm-hmm.
And in some areas, do you see that they're blue cells or are they pink cells?
Kind of pink.
Yeah, and in this area, take a look at this cleft. What's off about this cleft for BCC?
There's something inside the cleft. Is that decapitation secretion?
Close. It's not, I mean, it's not, there is something inside the cleft. What do you think it is?
No idea.
What color is it?
Blue.
Blue.
So
Pale.
mucin, maybe?
Mucin. Yes. It's mucin clefting. If anything. Not just that there's typical retraction. In fact, we see clefting, but it's just a clefty tumor. See, it's clefting all over the place. And it's producing this mucinous area, and it's not quite basal. It's something off about this. So this can look very much like it. Any ideas? You might have seen it already.
This is also an EMP-SGC.
This is also an EMP-SGC. Yes. So it can be tough. It can be tricky. So this, I don't think you'll get one as tough as this one, because this one really does look like a basal. If they ask you EMP-SGC, I think they will more likely ask you this one. This is the prototypical one that they like to test, right? This kind of inverted pattern of mucin with this pseudo rosettes or cribriform architecture. And they may even tell you it's from the eyelid. And someone actually mentioned, I think someone may have mentioned this, but we also have this papillated neoplasm here. But where is it from?
Volar skin.
Okay.
This person needs to lose their finger, unfortunately.
Okay, I didn't quite hear you. You're a bit low on the mic.
This patient unfortunately needs to lose their finger or toe.
Yeah, this patient may unfortunately lose their finger. I agree. Why?
So
Why are they going to lose their finger?
it's aggressive. It's a papillary digital carcinoma.
Yeah, I think technically, I think yeah. So that's the old name. I think we dropped the word aggressive from the tumor, even just for I think maybe for some.
Are we really being that PC?
I know, right? We really are. I think they did. I'm not. You can look this up, but I think they actually dropped the word.
We can't say anything anymore. Are we going to drop indolent as well?
Yeah, we dropped. We're gonna just. I think they just didn't want to scare the patient, even though there's reason to be scared. But yeah, I think now they just call it digital papillary adenocarcinoma.
And you don't necessarily, I mean, back in the day, yeah, they did start lopping people's fingers off, but that's not necessary for all lesions like this. What's important is if you ever get back a diagnosis of like a hidradenoma from your dermatopathologist and it's a biopsy from the finger, they're probably looking at one of these. So
yeah. So location, everyone. Antenna gotta go up for this entity if it's on the finger. All right. Let's take a look at this.
Syringofibroadenoma.
Okay, good. Why you say syringofibroadenoma?
Like elongated rooted ridges with sweat duct structure.
Okay, and notice how when they connect, they have these vessels inside. They surround these vascular structures. It doesn't go really far down, but yes, this part's syringofibroadenoma, as is the part over here. But what about the middle part?
Is a poroma or
It looks paroma-like, but there's a little bit like atypia, maybe some mitotic figures.
Yeah, like here.
yeah.
There's definitely mitotic figures here. There's one over here too. But yes, I agree. Like so like continue. You're all on the right track.
Like this area looks like porocarcinoma.
Yeah. Now, so yes, that's what this is, a porocarcinoma. Now, it's a little controversy here because the way this was originally entered into Path Presenter is that it's a porocarcinoma rising in like a syringofibroadenoma. But I will tell you that sometimes you can just get this syringofibrinomatous metaplasia type of phenomenon that's reactive to an adjacent tumor. You can also get syringofibrinomatous metaplasia that sort of reacts to a chronic inflammatory state, chronic ulcers, extreme stasis that's gone on for decades. Sometimes we've gotten Mohs surgery specimens from like really chronic inflamed stasis dermatitis. And you can see this type of syringofibrinomatous metaplasia, and it's just incidental. So it may not be the syringofibrinomatous metaplasia here might just be reactive to the porocarcinoma. It's not necessarily the case that you had a syringofibroadenoma and then a porocarcinoma arose from it. But you're not responsible for resolving that debate. But yes, good. You guys are doing great. I think we're on our last one. I don't think they're actually going to ask you, ask it to give you an example. Actually, we probably won't do this one because actually I've never seen it asked like this, but this was supposed to be a sclerosing sweat duct carcinoma, which I'm not even sure is all that distinct from a MAC. But you can see the strands of cells here, but they typically ask a more obvious example. So we'll treat the last one as our last case, but you can see the ducts over here. Okay. You guys are great. I'm actually very impressed you got that last one. You got both the syringofibroadenoma and the porocarcinoma. So great job, guys.
Thank you, Avi. We appreciate you.
All right.
Got it.
See you next week.
Yeah.